Well, thank you everyone for being here this morning. We're really excited to kick back off the Health Cities breakfast, and we're really glad that you're all able to join us this morning. Really excited about the topic at hand, which we'll talk about in a moment. But just to get started, we will start off, of course, with our land acknowledgement. We acknowledge that Health Cities operates on Treaty 6 territory, the traditional gathering place for many First Nations, Métis, and Inuit peoples. Health Cities recognizes the Indigenous communities in our work and emphasizes the crucial role that Indigenous peoples have always and will continue to play in leading health and health innovation. I also wanted to recognize our sponsors, Edina Life Medical Labs. Thank you very much for your support in helping out for the breakfast this morning. Also wanted to recognize some key supporters. The University of Alberta, who's here, Ria, if you want to wave. The University of Alberta has helped sponsor 10 students to join us here. It gives them an opportunity to network with Edmonton leaders. So students, make sure you introduce yourselves and start talking and networking in this environment. And I also wanted to thank Kiwi Productions in the back there for all their support in terms of recording this event, which we'll have up on our website soon, I'm guessing. Housekeeping items, if all of you can just silence your cell phones. If you do need to take a call, please step out and do that. We will have our networking panel starting at 9 a.m. and we'll have the space until 10-ish, so if you're able to stay and network, please do. I also know many of you need to get your day started, so we'll let you on your way. So in terms of introductions, I'm just really excited to have this conversation. Many of you know that Health Cities is involved in health and health innovation. We know that health innovation is inextricably linked to our social services and our social environment. And so being able to strike this conversation between what we're doing provincially in health, what we're doing municipally is critical. And so I'm really glad to have Ryan Kelly here, who's been working with Health Cities a lot on this area, to introduce himself and then also our panel members. So Ryan, over to you.
Thank you, Reg, and good morning, everybody. It's really great to be back together again at in-person events. I think we can all agree to that. And I'd like to also thank the catering staff for the great breakfast this morning as well. This is a really exciting morning for us. I personally get to sit beside some folks that I've gotten to know over the last few years. And to see them all together on one stage to have this great conversation is really exciting for me, and I'm really excited about what we're going to talk about. But before we get started, I think I'll just do some quick introductions of all of our folks here this morning. Immediately to my left is Dr. Kate Story. Dr. Story is an associate professor in the School of Public Health at the University of Alberta, an applied public health chair, and a distinguished researcher with the Stollery Children's Hospital Foundation. Dr. Story's research program, called CIRCLE, which is an acronym for Settings-Based Intervention Research Through Changes in Lifestyles and Environments, focuses on school and community-based strategies to promote well-being, prevent chronic diseases, and reduce health inequities. Welcome, Kate. Sitting next to Kate is Tricia Smith, who's the Executive Director of Radius, formerly known as the Boyle Macaulay Health Centre. Tricia has more than 26 years of experience in healthcare and social services as a registered nurse and a Master's of Nursing in Leadership from the University of Alberta. Tricia is also a veteran of the Canadian Armed Forces and has worked with the Government of Alberta in health and community social services. Welcome, Tricia. And then we have Gary St. Armand. I always put an R in there for some. Armand. He's the CEO for Bissell Centre, one of Edmonton's leading providers of services and supports to help move people out of poverty and ensure their voices are heard in meaningful, empowering ways. Gary has been with Bissell for 10 years and has worked on a number of important initiatives, including an award-winning eviction prevention program, a permanent supportive housing program for people with FASD, and a financial empowerment program for people experiencing poverty and homelessness. Welcome, Gary. And last but not least, we have Dr. Karen Lee, who's the director of a program called Housing for Health, and she's an associate professor in the Division of Preventative Medicine within the Department of Medicine at the University of Alberta. In addition to teaching at the School of Urban and Regional Planning, Dr. Lee is also the author of a book called Fit Cities, which reflects her lifelong passion for improving housing and public health through design. Please join me in welcoming our panelists this morning. I got through all of those titles and all of those accolades without slipping too many times. Before we start and get the dialogue going, I just wanted to maybe level set a little bit on what definition of social determinants of health actually are. I think we hear this term quite a bit, but I think for the purposes of this conversation, I think it's really important to understand the context for this conversation. And social determinants of health are a relatively new idea in the context of the broader healthcare system. I think we're starting to understand more and more the role that these determinants play in our health. Simply put, determinants of health are the personal, social, economic, and environmental factors that influence our long-term health, from the neighborhoods we grow up in, to the strength of our social connections, to the income we earn. For example, we know that childhood poverty can have a deep influence on addiction and premature death as adults. So when we look at a health system struggling today to meet increasing demands, we need to look at the root factors that are leading to these connections. And we need to understand data points and use that data to make better decisions. So with that definition in mind, I'd like to start maybe checking in with our panelists. And maybe, Kate, I'll start with you. How do social determinants of health show up in your work?
Yeah, it's a great question. So I think first and foremost, when we talk about the social determinants, and I hope, can everybody hear me okay? Okay. They said to use my teaching voice. Oh, I'm getting a thumbs up at the back. I think it's something that we talk a lot about, and they're everywhere, and then they're nowhere. And so I think in terms of, and I'll provide an example, the social determinants, I think, are all about equity. And I think too often we conflate equality with equity. And so I'm going to give an example of what that means. And I'm an educator and I'm a professor, but I think that this example always resonates with me every time I talk about it. And I talk about it with children and youth because I most specifically work with children and youth. So if we think about trying to watch some type of sporting game over a fence, and there's a fence that's blocking us, and we want to see over that fence, equality is giving everyone the same box, no matter if they need a box or not, or what that box looks like. So you could be a taller individual, you have the box. Suddenly you can see over the fence and see that sporting game. Say you're a little bit more vertically challenged like myself, you get the same box, you still can't see over the fence. And what if mobility is an issue and you need a wheelchair? Just having a box doesn't make sense. Equity is giving everyone what they need. And so that might mean one box, two boxes. And then if we address the social determinants of health, what if we actually remove the fence and so we don't have those systemic barriers? So the way I see this showing up in my work is most often in education. So if health is truly a precondition for learning, not all children truly have an equal opportunity to grow and thrive. And so we saw that throughout the pandemic, and it was exacerbated. And so, when we look at children meeting different recommendations in terms of lifestyle recommendations, we know that children meeting more and more recommendations. So we did a recent study of children meeting 7 to 9 lifestyle recommendations. So diet, physical activity, sleep, and screen time had 3 times the odds of actually meeting expectations for reading compared to those that don't. But it's not about those lifestyles. It's about those social determinants of health that allow them to achieve that, to live in an environment where they can grow and thrive. The pandemic was also a really good case study for exacerbating those inequities in society where the social determinants of health were present. So I always like to say, in terms of the pandemic, we'd often hear that we're all in the same boat. We were all in the same storm. Some had larger boats than others, and some didn't even have a life preserver. And those kids that we saw, so where I see the social determinants showing up, is those kids that didn't have even a life preserver. We're continuing to see the implications of what happened to them because of the social determinants of health. And we will continue to see that, I think, for their lifetime. So we know some early stats about what that looked like in terms of literacy, numeracy, mental health, anxiety, and depression. And I know that this was in Alberta, approximately additional 15% of students in grades 1 to 3 will need literacy and numeracy support. It doesn't sound like a huge number, but that's twice as many students as were experienced in the past. And those that already needed supports need even more supports. So imagine if literacy and numeracy is an issue in grade 1 to 3 and there isn't an intervention, that's going to continue throughout their life course. And we saw from teachers, they were stressed about food security, safety, So we know in those home situations that that was a real challenge. The pandemic was in many ways a case study, but there are many stressors to our system where we can see the social determinants show up. So that's one example. In terms of anxiety and depression, we also saw that that was happening. And I think that this is becoming more and more prevalent in today's society with youth. But a study from the University of Calgary looked at 29 separate studies and found that depression and anxiety had doubled in children and adolescents. So we can't continue to just try to fix the problem. We have to address it at its root cause, move upstream and remove that fence so that we don't need the boxes. We're still gonna need boxes, but hopefully not the amount of boxes that would be in like an Amazon distribution center. You know, the goal is to have less and less of those boxes. But that's something that we see and that I've been seeing most recently in the work that I've been doing.
That's excellent. Thanks. And there's some themes there I think we'll come back to at various points here. Tricia, how about you? I mean, in many ways, you're at you see the deep impacts of social determinants of health down the line. And so I'm curious how it shows up in your work.
Yeah, for sure, Ryan. Thank you for that. And I can hear myself echoing, so I guess you can hear me at the back. Social determinants of health shows up every single day in the work that we do at Radius Community Health and Healing. Frankly, it's the reason we exist. So for those that don't know what Radius is or where we are, we're located just on the edge of Chinatown in Edmonton's inner city. And really our mandate is to provide access to, we're a community health center providing access to health and social services for individuals that have barriers to accessing healthcare. And so, you know, we're the one place that the College of Physicians and Surgeons actually allows us to filter out specific patients to provide service to. Any other physician providing, you know, community care, you're not allowed to pick and choose the patients that you serve, but we're allowed to pick and choose because we take the most complex, the ones that have barriers, the ones that are impacted by social determinants of health, the ones that have low income, the ones that have no housing, the ones that have really complex health issues, severe and persistent mental health. And a lot of it is coming from a lot of the things that Kate has just talked about. So adverse childhood experiences is a basis foundationally and theoretically for a lot of how we approach our work. And that really, it shows up every single day visibly and invisibly in the patients that come to serve us. A lot of them don't have natural supports, that social connection. A few of us were having a conversation about the absence of connection and how impactful that is to your long-term health. A lot of them don't have friends other than each other living on the street. Low literacy levels, low education levels, that impacts their ability to earn a living. So again, I could go on with the list of social determinants and how it impacts them, but just, you know, every single day, that is why Radius exists, frankly, is because of the impact on social determinants of health, yeah.
Yeah, and I know, Gary, you and Tricia have a very sort of close geographical relationship, but also in terms of the programming and the services and things like that. Anything you want to add to that in terms of the populations that you serve in particular?
Yeah, I would say probably the easiest answer is ditto, but you know, I think it's probably, you know, it's easiest for me to speak about it in terms of the lack of access to health. And so I'd start with that statement saying we need more of Radius. We really need more health, more access to health. And when you think about that from a statistical perspective, it's sort of, you know, facts and figures, but our teams live, you know, day in and day out with the very real human impacts of that. And so, you know, people often don't think about things like foot care. Like we had a funded foot care program that we lost our funding for, so we funded it ourselves because the amount of need for people who are walking, you know, literally kilometers and kilometers in the same pair of shoes and in the same pair of socks that get wet in this snow, and then, you know, start to build all of the things that create, you know, and you know, Tricia knows that all too well, right? But that's just one example of so many ways where the impacts. If you don't have identification, if you don't have an Alberta health card, how do you get access to medical supports? When we're working with folks, we don't know as they're being discharged, you know, and I know some of that has, you know, come up in the media, but we don't know if they actually are discharged with significant health challenges or not. Do they need access to, you know, Tricia's team? how do we deal with that? And then we see people, who are literally dying in our facilities across the community because they don't have the proper access to healthcare. And I remember when I came into Bissell, somebody said to me, how many people who are houseless have you seen that are senior citizens? You won't see really any because they don't live long enough. That's the lived impact, I think, that we see kind of day in and day out.
Yeah, and housing, as you mentioned, is such an important part of that, and as early and as stable as possible in someone's life, right? To be able to course correct in that way.
Yeah, absolutely. And I think, Trish was talking about support networks and health, and we in our data are tracking indicators, multiple indicators, and then we're able to correlate, and we can see a clear correlation between people's support networks and their retention of housing, right? And so some of those things are just, these things we're not compartmentalized as human beings, we're integrated, right? And we have to perceive it from that lens.
Yeah, that's really interesting. Karen, I know you do a little bit of work in the housing space as well. Also really interested in your work around urban design and the impact of urban design on human health. Do you want to talk a little bit about how determinants of health show up for you?
Yeah, absolutely. Can everyone hear me? Okay, fantastic. I think if you look at Public Health Agency of Canada definitions about the determinants of health, health care is only one of the 12 determinants. Many of the other determinants, and of course biology and genetics is another one of them. We often hear about these two major factors as, they're covered in the press very frequently in our dialogue as the determinants of health. But actually there are 10 others, right? Our physical environments, our social conditions from, as you said, Ryan, like income, education, that's been brought up by our panel. Even not just individual incomes, but income inequality in itself actually has impacts not only on those with low incomes, but those with high incomes as well. Right? So for example, there are studies that have been done on income inequality in comparing, for example, societies with larger income inequalities, societies with lower income inequalities, like Britain versus Sweden. And not only did they find better health outcomes for things like infant mortality in those with lower incomes, in Sweden, for example, they found those better outcomes in those of high incomes as well. In Sweden compared to the UK. So there is something about social conditions that don't just impact us individually, something about the collective that actually has impacts on all of us. So I think I want to make the point initially that, inequalities, inequities, societal conditions impact us across the spectrum of incomes. Clearly, they disproportionately impact those who have low incomes and are disadvantaged in many ways, but they actually also impact those at the highest levels of incomes as well. So as a society, we can't actually afford to ignore that. So how do we start to address, I guess, these issues of inequities and inequalities? Well, research does give us, evidence of interventions that could work, correlations of different types of conditions and outcomes. And as you mentioned, Ryan, our environmental conditions that we live in, that we work in, that we might go to seek care in really does impact our health. And so how we design those environments, how we organize them socially in terms of how we organize work, right? Can impact the health outcomes of folks. How we build our physical environments, so where we live. If we live in a neighborhood, for example, that's walkable, studies actually show that that's associated not just with walking and physical activity, but with people running into each other and increasing social connections, with decreasing crime because there are more eyes on the street. So how we design our environments consciously versus just letting it do whatever it wants to unconsciously can really ultimately make a difference. Yeah.
Yeah, great points. I want to pick up on something Kate said, and she used the example of COVID and the impact that it had on young adults and young children specifically. But there's also a family around that child, and the stress of COVID and fragile employment and the impact that that was having on families. I think it was a good example of something that we didn't really recognize as a determinant of health. What is a family environment like where a child is growing up, and is that a stressful environment? So I wanted to talk a little bit about other things that we may not know about determinants of health today, that we should know and that we should be planning for from a policy point of view. I don't know if anyone wants to jump in on that. I'm happy to go down the line if we want to do that as well.
Sure,
I'll just
she
jump
looked
in.
like she wanted
I'll
to jump.
just jump in.
You
Sure.
can't do the line every
No,
time.
the line's boring.
It feels a little bit too...
Yeah, exactly.
So, when we talked about this in our pre-discussion a little bit, Ryan, I think for me, it's a little bit of maybe we don't know what we don't know. As I've been very clear, but I'm not a researcher. I'm a frontline leader, and so for me, I always have a lot of questions, but I don't necessarily have the opportunity to answer them. So the things that I wonder about are what impacts do social determinants of health have that we haven't studied? How do we even know what questions to ask? It's human nature to look for cause and effect relationships, and even more so when we're trying to do research, we're trying to look for cause-effect relationships. The things that I guess I have questions about is there combinations of social determinants of health that are more negatively impactful when those are negative experiences? And on the flip side, is there more specific social determinants of health or combinations of those that can be more protective if there's a positive experience in that area? So having a negative experience in income, but if you've got positive social connections and positive relationships in your family, is that more protective than the negative impact of having low income? And I always wonder about like those sort of variables. What are all those variables, and how do we control for those things to actually look for cause and effect? And then the so what is always, so what do we do about it? Right. So that's the thing. I've always been intrigued as a nurse about when I was doing frontline nursing, direct patient care, is that connection with a patient. I always made a really intentional effort to make a connection with the patient, make them feel like I was there just for them. And the difference that made in their healing was huge. And so for me, I'm just really curious about, is it social connection that is the key to really minimizing the impact of other social determinants?
Yeah, great point.
Yeah.
Anybody else want to take a run at that?
I can pick up on it because I don't know. I'll just scream in case. Oh, there we go. I think just picking up on that comment and I always joke that I don't have many professional titles. I'm a researcher, but we're all researchers. We're all scientists. But I think in terms of the social determinants of health, if you think about an individual, they certainly live surrounded by their family, their community. They don't live in a bubble. But I think far too often with data is that we try to kind of distill down some of those very unique characteristics. And so I always say, in terms of looking at trying to understand this, we really need to understand the lived experiences and the intersection of the multiple lived experiences and realities. And I think we don't do that enough. I'm biased. I'm an implementation scientist, so I like to understand what works for whom in what context, primarily a qualitative researcher. But I don't say it joking, but I think too often we prioritize things like randomized control trials where people become numbers, as opposed to real community trials where we actually try to really understand a day in the life of somebody walking through and existing. And that's where I think the magic happens, is those intersections of experiences. And I think we can really learn a lot from that, as opposed to trying to reduce it down and then end up just providing the same boxes to everyone, for example, from an equality lens. So just picking up on that. That's what makes me curious at night and during the day. And always.
I mean, I think it's really interesting that the data space doesn't make a lot of room for lived experiences, and there's rightly an important discussion about data and doing it better and getting better information out of the data that we share and that we collect. But how do we create space for lived experiences in that data, which is really the fabric of what makes somebody's experience really important? You two, any reflections on that? What are we not talking about in terms of determinants of health that we should be?
So I guess my thought, building on what Kate and Trish have just said, is really, when you think about that concept of intersectionality in the literature, when it first came up, and I'm sorry I'm forgetting the name of the author, but there was an article, all women are white, all blacks are men. And the point of that article was to say, it's not just that as a black woman, it's a compounding pressure. It's that policy is being constructed in a way that excludes you on both fronts. So you have no access to the supports that might be available to one or the other. And so I think when we think about our data and our learning, part of it for us is we're asking those questions so that we can think about how we organize ourselves as a community, as a society. And so we have to be careful when we want to, compartmentalize, which often we have to do to create sort of those streams of learning that we can isolate some variables. But fundamentally, if we don't sort of, again, come back to that human lens from that perspective and how we're thinking about how those data points intersect, as Tricia was saying, with all of the different components, then I think we risk that we actually think we have done something, which is worse than not having done it all, because at least then we know we didn't. But now we think we've supported something that we haven't, right? And so I think our data and analysis has to really be thought about, and your point about, then the voices of lived experience becomes paramount in that conversation, because they're the ones that will, tell you that you've missed the boat with your research, right?
One of my favorite expressions is the term strange bedfellows, and I like the idea of thinking about creative partnerships to sort of break down some of the barriers between data and lived experience. Maybe, Karen, are there any examples, or do you think what role do partnerships play, or creativity around how we think about determinants of health?
Oh, I think it's absolutely critical, and I think. Also following up from your last question about what are we missing related to the determinants of health? I was going to say, I think if we're serious about the determinants of health and truly improving the health outcomes and health care outcomes of society, then I think we need to, as a society, across multiple sectors, private, public, health, non-health, start to work together to actually address these determinants. These determinants are not addressable only within the healthcare sector. And yet, of course, it ends up impacting our healthcare systems, the load that we see in the healthcare systems, the sort of unsustainability of it, the wait times. And so I really think a really major piece is how do we partner together across sectors to do all that we can to improve societal conditions, socially and physically, in all that we can do, in how we measure, but in also how we intervene. So, all of us work in a workplace. And one of the things to ask is, how healthy is that workplace, for example? Are there places to eat healthily nearby or in the workplace? Can you even, for example, use the stairs and use that as a daily active living measure? Do you have a standing desk that allows you to be less sedentary throughout the day? How do we organize that workplace? Do we organize it such that staff feel supported? People feel empowered to have control over, for example, some control as much as they can over their work lives, because job control, actually, and job social supports, and how we reward people for their efforts actually have been shown to be associated with multiple health outcomes like cardiovascular disease, injuries, mental health at work. So what role, I think, can all of us play in our own work lives and community lives to actually play a role in creating the healthier social and physical environments that we all need to thrive and to do well health-wise?
Yeah, I think it's a great point, and to Gary's, Gary talked a little bit about things like foot care, as a small but a really hugely impactful thing on someone's quality of life. And there's probably no silver bullet to your point about social determinants of health. It's a combination of a bunch of things sort of coming together to improve quality of life. Are there any other partnerships that you think we should be pursuing, either of you? Anything you've seen in your work that really surprised you from an outcomes point of view?
I mean, I'll just leave with one quote, but I think, as an academic, I think far too long, I always say academics love to talk to ourselves about ourselves. And I think that can be said for any, different field or discipline or sector. And so, I think events like this are so important because it allows for that kind of mixing and mingling between sectors. So I'm not going to provide an example, but just the reality that, even in the academic world, and that's the world that I come from, it's only been very recent. I would say, one of the most significant changes that I've seen in our work is a focus on knowledge translation, knowledge mobilization, working across sectors, so research, policy, and practice. But why are we only just now there, right? So there's a lot of catching up to do. I think there's a lot out there, and there's a lot that's been done, and there's a lot of good work. And so I'm an optimist. I like to be, think positive. I think there's a lot of success stories. There's a lot of excellence. There's a lot of brilliance out there. We just don't know about it, and we haven't figured it out. So I think that, for me, that's an example, just in my work of saying all of this evidence, all of this work is there, and that has to be true in other sectors as well. It's just that there needs to be more cross-pollination, and unfortunately, I think the pandemic really stalled a lot of that. I don't think there's any. Sorry, go ahead. I don't think there's any, I'm a community-based researcher, so I need to be with people and around people, but I don't think there is a replacement for that face-to-face social connectedness that can advance this.
So I will agree with you on the silo piece and that we tend to get focused on our own work, whatever it is and whatever sort of aspect of health or social services that it is. And I think partnerships are critical. Frankly, it's the only way that we can truly be successful, and I'll give a couple of examples. So for me, when I look at a community health center model, selfishly, I'm going to look at that. It is actually the main reason why we are able to be successful with our clients is because our programs are integrated, not just health. So we don't just have primary health care in our organization. We've got the wraparound supports that need to go with that to support that individual across all aspects of their health. The part that I was tripping on when you were stating is that the pandemic shut down a lot of our connections and partnerships, but it actually created some new ones. So through the pandemic, there was a significant need for groups to come together to support individuals experiencing homelessness as a result of impact of, whether they were COVID positive. They had nowhere to go to isolate, to prevent spread, that kind of stuff. That was huge, and I'm looking at Gary and we're nodding because this was a huge community partnership across the sector to provide those services to those individuals in a significant time of need and emergency. And as a result of that, I think it opened some doors that those doors were always unlocked, but they weren't necessarily open. And so it's allowed us an opportunity to connect and converse and discuss our programs and our services in a way that we'd never had before, or that we hadn't in a long time, at least as a group. And I think it's left that opportunity still rolling. And do we need to do it better and more? Yeah, 100%. Do we need to do it across other sectors? Yes. One really good example is corrections. When people are discharged, released from corrections, whether it's just the remand center or the overnight 24-hour hold, or they've been in jail for 15 years, often there's no plan. They're just released. Where is the support? What's the next step for them, and how do we make sure they're getting the right connection before they're released? It's just one example.
And starting to break some of that cycle.
Yeah.
Gary, and I know both of you had some reflections on that previous question. Go ahead, Gary.
So I think one of the pieces that we haven't talked about is the impacts of colonization in this conversation, and Indigenous ways of knowing. So talk about learning and understanding. And I think about, I was sort of doing a thought exercise a while back about, what was it like growing up as a kid 300 years ago in North America versus 100 years ago, 50 years ago now. And you think about ceremony and celebration and how people would be gathering with their community and doing these things and learning and engaging with elders and multiple generations. And we talk about the impacts of that. And now I think about, myself growing up as a kid, we didn't do those larger community things as much, but we certainly had, 20 people at the Christmas gathering or, the family events. And now I watch my kids growing up and it's like, well, you need to go out on the, to play with your friends on the street. Well, there's no one to play with on the street, Dad, because they're all playing on their video game systems in their rooms. So if we don't go into our room, we don't actually connect at all. And so we've actually used technology to really isolate our children from each other in a way that sells more units. So how are we thinking about this from a technological perspective, but also from that lens of how our Indigenous communities actually have something to teach us in our meta narratives about, maybe we have overemphasized the value of individualism to the point of isolation, and we're actually in a dysfunctional space as a result. And so then the impacts of that, really start to reverberate in terms of this conversation.
Yeah, I think which speaks to the importance of community spaces, community initiatives to try and bring people together for social connections, for, having somebody in your corner when you need them, all those sorts of things. It's really important and really tangible things. Karen, you were thinking a little bit about that previous question too.
Yeah, I wanted to expand on the partnerships conversation, right? I think my previous comments may have suggested that, there's just these kind of nebulous or generalized partnerships. But I didn't actually mean that. I think what I was trying to emphasize was that, everyone has a role to play in the determinants of health, wherever they're working, whatever they're doing, and as a community member. But the partnerships are going to be specific to where your area of work or where you live lies, right? So for example, if you work in the sector that I work in or the research that I work in, housing for health. We're trying to improve housing developments and the neighborhoods around them for health. So we partner naturally with housing developers, both for-profit and nonprofit developers. We partner with municipal planning departments that can shape the neighborhoods, and urban designers in those departments that can shape the neighborhoods around them. We might partner with a supermarket developer or operator to improve the healthiness of their offerings in that neighborhood, or to try to locate in a new neighborhood so that there's healthy food nearby. There's roles to play with parks and recreation, with schools in terms of the infrastructure. So if you're an organization, let's say your organization is planning on building a new building, there's partnerships to be had with your architect, right? And how they're going to design that building. You might make decisions with your facilities folks as to where you want to locate that building so that maybe it's in a healthier neighborhood where your staff can actually access healthy foods, walk around, have access to public transportation, maybe bicycle infrastructure. So, if you're a company that actually builds measurement devices, one of the questions is, can you build measurement devices not just in the healthcare setting, but to measure and collect data on, let's say, community resident use of healthy amenities versus unhealthy places? So I think the partnerships that we will strike will depend on our specific area of expertise and what's happening currently in our own context. But there's always partnerships to be had. And I would also, I think for us at the university, I would say that if you're doing something really innovative with your organization, how can researchers, for example, at University of Alberta in different fields, help you to potentially measure those health outcomes, to evaluate those health and potentially other outcomes, from the innovative things that you're doing?
Yeah, and that's a great point, because the School of Public Health at the university is an incredible asset that we could be able to leverage to pursue some of these partnerships as well. I mean, it does sort of lead to my next question of where are the opportunities for innovation in this space, if you were to think about it in your own world? I don't know if you want to kick us off, Kate, on that one?
Yeah, and maybe I'll provide an example of this may not seem quite innovative, but to us it's been I would say quite substantial in terms of just one project that I'm part of. So there was a project that started almost 20 years ago called the Indigenous Youth Mentorship Program out of urban Winnipeg, and I now have the pleasure of being one of the co-leads as part of like a really richly, deeply connected team across Canada with 50 communities. And the project started as a program to help prevent type 2 diabetes in children, so smaller children, elementary school children. And what it is an after-school program, and older mentors provide the program after school to these younger elementary students. And it really focuses on creating a sense of belonging through the circle of courage, but also physical activity and nutrition, so healthy snacks. And so it started off that way. And the innovation of the data was that, yes, we're embedded in school communities, and we wanted to ensure this was sustainable. It's wonderful, and we saw improved health outcomes in terms of reducing type 2 diabetes risk factors, and it was a success story. But as we started to listen to the youth and to listen to the school communities, we realized that the impact was much greater. So it's one thing to prevent type 2 diabetes, but if children and youth were not graduating high school, having life skills or employability skills, then what were we doing? We weren't addressing the social determinants of health completely. We were in many ways. But that was where innovation happened, of thinking about this program not necessarily as a type 2 diabetes prevention program, but as a program that could really, truly honor and work with the youth mentors to ensure that they graduate high school, to ensure that they have the employability and life skills. And the data and listening to the voices is what told us that. It was a subtle change, and I think that that's maybe where innovation can happen. It was a subtle change in working with the youth mentors and working with the school communities to shift our focus away from the measurement and the data with the youth, the young children, recognizing that's going to happen already, but how do we work with those high school mentors? How do we work with the school communities to ensure that the students graduate? And this happened because we heard from the program that on the days the program is running, the kids want to be at school. They want to continue to go to school. So we've had many, many students that have gone through the program as a youth mentee, like receiving the program, to becoming a mentor, to becoming a community lead, to becoming a coordinator in their province. So that is a story of something that I feel like is innovative and started small, and we made a subtle change, and now our entire focus is on working with those youth mentors in terms of not empowerment, because they're already there, but in terms of resurgence and identity and belonging and fostering that throughout the lifespan, as opposed to just that isolated school incident.
Yeah, exactly. Tricia, how about you?
I think your points are really valid, Kate, and I think for me, as I was pondering the answer to this, responding to this question, I think we need to remember that we don't have to boil the ocean. We need to bite off a small piece, and even if we're starting with this particular goal in mind, when we look at program evaluation, when you're designing a program evaluation, you're always looking at what were the goals of this program intended to do. And I think what we end up doing at the end of that evaluation is sometimes there's a bunch of benefits that we didn't really realize, but we also realize we can start, it's just a building block. It's like building a Lego house, right? Let's start with small pieces and then build as we learn what's successful. I think sometimes we try and boil the ocean because it's so complex. So we just have to bite off small pieces. I think for me, where do we start is often the question, because it is so complex. I think the thing is we just have to start. So let's start with housing. Housing for me is, there's a lot of discussion about permanent supportive housing. We need more permanent supportive housing, and we need more affordable housing. And to me, that's the spectrum. Affordable housing and permanent supportive housing. And what we forget is all the stuff that's in the middle. There's a lot of stuff in the middle. There's a lot of gaps in the housing system in the middle that we don't take enough time to talk about to try and fill. Some people need affordable housing that they can live in market and independently, and some people need permanent supportive housing. But there's a lot of people in the middle that don't need either ends of those spectrum, and we're not talking enough about those middle pieces. And I think that's where we need to focus some of our energy, and where I am personally focusing some of my energy as in my role. So yeah.
I'll leave it to Gary and Karen to wrap us up with some thoughts on that, on the innovation and where there's opportunities for innovation.
Your turn to go first.
Oh, my turn to go first. Okay. So I I want us to think about innovation in, for example, partnerships, right? When it comes to the work to improve health outcomes. So in our Housing for Health initiative that you mentioned, the working together, for example, at the University of Alberta, not only do we have, for example, me in the Division of Preventive Medicine in the Department of Medicine, and Kate's a partner to us in the School of Public Health, but we actually have 8 other faculties involved, right? So for example, there are folks from kinesiology because they are experts in, for example, physical activity. We have folks in computing science looking at, are there ways to use AI to measure, for example, use of amenities within our community context? We have folks clearly from School of Urban and Regional Planning. We have folks from engineering. We have folks from agriculture and nutritional sciences. So I think thinking very broadly about about innovative partnerships, I think is a really important piece of that. I want to touch also on, I think, innovations in housing and the neighborhoods around them. I think often we sometimes think about, the need for, when we talk about affordable housing, often in the Canadian context, we're talking only about low-income housing. And that is absolutely critical because there's not enough supports and sufficiencies of truly affordable housing. But there are many communities now and societies that have started to look at affordability across the spectrum of contexts, right? So, for example, when I was working in New York City prior to coming back here in the health department for Mayor Bloomberg's administration, one of our partners was the affordable housing folks. And they were looking at not only ensuring and creating more affordable housing and preserving affordable housing for the lowest income folks, but how do you actually preserve and increase affordability for more middle income folks as well, because it's such an expensive city. A lot of people, I think, don't know this, but I've done some work with Singapore. And in Singapore, over 80% of their population actually lives in some form of government subsidized housing, right? And so one of the ways to address, as cities become sometimes more successful and expensive, is to ensure that housing supports occur across the spectrum. Definitely and very much needed for those of low incomes, but increasingly when cities get more expensive, we also have a role to think about how do we ensure supports for those with middle incomes who may also be struggling with affordability in those cities.
Gary, any final reflections from you?
Yeah, I think when we think about innovation, we sometimes confuse it with creativity. And to me, innovation is something that requires a lot of discipline and rigor. And I think it requires testing our assumptions. So my experience has been, over the decade that I've been at Bissell and years previous, I won't say how many, we often see sort of almost become addicted to this idea of innovation in and of itself. And I think we need to be careful about that because I think we need to keep innovating. So I'm not anti-innovation, just to be really clear. But there are moments where we do truly innovative things and then we refuse to invest in them to scale. Or we, don't think about how they might be applied, in other, locales or those kinds of things. And so part of, I think, the rigor of innovation is really trying to go, how do we make sure when we actually come across true good innovation that's going to be impactful, we're ready to support that innovation to have its full impact. So I would say that's one of the significant pieces there. And I think the other piece of that goes with it is really testing our assumptions. So there's a famous study called the Cambridge Somerville Youth Study that took place starting in like the 40s and going into the 70s, where there were youth that were part of the justice system, and they were in this small community and being released. And a bunch, about half the youth got involved in a program that were supporting them with mentors, and the other half of the youth that were in this community that had been released from the system were not. And so the researchers said, look, we actually have a natural control group. Let's observe this over the decades. And in the 70s, followed up with these youth as adults, and interviewed them and said, what was your experience like? And having the mentor was great. But then also at the time had access to way more data points than we're allowed to now. Started to look at all the indicators that went along with them. So recidivism, income, education levels, all those things, all the social determinant of health markers. And the youth that were not part of the program fared significantly better than those who were part of the program. To the point where one of the researchers who was a mentor immediately quit being a mentor. And so I just think that sometimes we assume if we do X good thing, it will result in Y good outcome. And we have to really, I think, challenge that, because what I see is a lot of the assumption and research and policy development that happens is based on some core assumptions that I'm not always sure are accurate.
Yeah, amazing. Well, I wanted to thank you all for the very thoughtful conversation today. I think we've got a few minutes for questions from the floor, so I'm going to pass the mic to Danny if there's any questions on the provocative conversation we've had.
Any questions?
Everybody's carb loading from their breakfast.
John Sproul with the Institute of Health Economics. So I'll ask the question based on money, because I think in all this, who pays? I mean, is this, because that's a bit of a challenge in how we address some of these programs that improve well-being. How do we deal with those partnerships where it's to gather the particular kind of funding? Is it a responsibility of the health system? What gets generally covered? How do we deal with the financing of some of these particular efforts? Are there any kind of calls for action or lessons on that? Certainly, I've always said that Radius, Boyle McCauley and Radius and Bissell, they should just triple their budgets and not ask for tons of evaluation, because we know they do good, but for those vulnerable populations, and sometimes we demand a lot of community agencies to get over-evaluated on very small amounts of money, so that's just a comment. But how do we deal with the financing of some of these kind of issues, and what is the combination or steps we might move forward?
Oh, that's a great question. It's one that I ask myself every single day. Where am I going to get the money to do X? And I wish it was an easy answer, and I think you wouldn't have asked the question if it was an easy answer. For me, I think it's multifactorial. I think there's a role certainly for government to play in funding and truly doing research, but also there's a role for community, because it is all of our roles, frankly, to ensure and promote the health of our society collectively. So I think there's a role for everyone to play. And I appreciate the comment about, just up the budgets of the community organizations and let them go about their work. Because that's where the magic happens. And I believe in that, but I also believe that government, that is part of government's role, and so therefore they should be putting that forward. Now, I think the question comes, which sector of government? And I think that's part of the issue that we face all the time is this health, or is this community and social services? And I frankly wish they would stop fighting with each other, and I've actually worked in both places, so I can appreciate both sides of the coin. But yeah, and I'm not answering your question at all, other than to say it's everybody's role, and I think the funding per se needs to come from multiple different places so that we all feel accountable and responsible, frankly.
Can I add to that? I was just going to say that I think more monies do need to be invested in the upstream determinants, in the determinants of health, and in prevention that actually, and disease management that invests in the community and those physical and social environments that support either management of disease once you're sick, or in the prevention of disease in the first place. And I don't mean investing in a media campaign that tells people just, how to be healthier in their lifestyle. I mean, truly investing in all of the different social and physical infrastructures that are needed for health. So that's one piece. I was going to say, one key thing, though, that I've learned working with these different sectors, like when I work with developers or with architects or with urban planners and designers, is that things don't always have to cost more money. You can consciously design or plan for initiatives or for elements in what you're going to already be doing that incorporate the health and well-being lens from the get-go. And then it doesn't have to cost more money. So for example, if you're building a building, whether you have your stairwell right in front of you when you walk in, that actually has been shown to promote use, versus sticking it in the far reaches of the corner, you're still building that stairwell. You're still paying for all those materials that go into that stairwell. So consciously thinking about incorporating, I think, the healthy planning, the healthy design lenses right from the get-go can actually get you more health bang for your buck, for the same buck. So just wanted to emphasize it doesn't always have to cost more money if you consciously incorporate health considerations from the get-go into everything that we do, I would say.
I think there's another question coming, but I was going to say the answer's in the room. We should just have the Institute of Health Economics to show us what the return on investment is of prevention. I mean, this is truly, don't ask us. You're the experts. I rely on your work all the time.
Yeah, go ahead.
Is it working now? Yeah, thank you. Sorry about that. Excellent panel, and you're really making thoughts show up in my mind. I'm John Lilly. I'm a member of the Premier's Council on Charities and Civil Society, and some of the findings we have found are that social agencies don't have time. They're busy delivering the goods. They're doing first-line care. And innovation and work with other agencies takes effort. It's hard work. It requires more than side of the desk. It requires front and center effort to achieve the best results, obviously. I'd like to turn the mic over to Gary, if that's okay, because he had his hand up too.
Sorry, John, did you want a response from them on anything? Oh, okay. Hi, everyone. My question, it's not so much a question, well, it is a question. Maybe it's a loaded question. But, I mean, the panel started by talking about social determinants and how we understand social determinants, and then started talking about, well, how do we address social determinants? And all I could think about was, and I can't remember, somebody talked about people with lived experience and community members. Maybe do we not understand social determinants as well as we should because we have the wrong observers and the wrong instruments? Because it's, I mean, no offense to all of us, but maybe we're not the ones who should be actually determining what the issues are and also determining how investments are made and what's prioritized. Any thoughts on the overall power structure in society and how we might be able to address that?
That old thing.
That old thing.
Yeah, go ahead.
Yeah, I mean, did you attend my qualitative and community-based research course earlier this week? Absolutely. I mean, I think that we have a lot of work to do in this space, and there's all sorts of different prioritization exercises in terms of how do we address these things within the Public Health Agency of Canada space and those types of worlds. I think there's a lot of room for different data and different ways of knowing that we haven't really honored and valued. And again, I'm a qualitative researcher, I'm an implementation scientist. My bread and butter is working and honoring youth voice and celebrating youth voice and making sure that they're the ones driving change for their own lived experience. But I think that applies to everything. I think far too often we rely I think numbers are important, certainly, and outcomes are important, and we need that data, but we need that in partnership with other ways of knowing that really addresses that humanality and the lived experiences, and again, that intersection of lived experience. So I would agree, and I think we have a lot of work to do in that space. I would say we're starting to see more and more of that being recognized and honored. It was a long time where it wasn't. And so I couldn't agree with you more. I think, though, at the same time, we need to do I think we need to do the best that we can with what we have, while recognizing that we can do far better, and that we really need to understand and honor our current cultures, plural.
So maybe I will, first I'm just going to respond to John's comment to say, to do a shameless plug for Health Cities, to say, we're working on a collective partnership with a number of agencies around how can we share data, which is actually more complicated than it sounds. And having tried to do it for a long time now. And I think when we have folks like Health Cities that can come in and work with us, and not work with us so that they can extract what they need from us, but to support us in helping, in terms of the journey that we're trying to understand of what we're doing to achieve those things, and been appreciative of Ryan and Reg and their posture in that conversation. So I think those are important pieces, because you're exactly right, John. We are running breakneck speeds trying to do the collaborations generally off the side of our desks, and so I think Giri. I mean, we've had these conversations a lot. Of course, like, we absolutely have just the scale of that equality of engagement and input and ownership of how we learn and research and have conversations has been deeply unequal, and that sort of just world fallacy or confirmation biases, all those things just are allowed to then run rampant. And
I know Karen has something, but I just want to pick up on power as well. I think that I think we also need to be mindful of the ethical implications of understanding lived experience as well, and whose data it is. So borrowing from OCAP, so ownership, control, access, and possession, and for what benefit? Like, are we looking and understanding lived experience for the benefit of ourselves, or is it for the benefit of the community holistically? And so I think we really need to think critically about that, and not just generate data, not collect because it's not ours to have, but generate it in a meaningful way in which there isn't a risk not only to the participants, but to the community and society. So I think I wanted to make sure to address that too, because it's one thing to say we need to understand lived experience, but why?
Right.
Yeah. Sorry,
Karen, last word to you.
So I wanted to address both John and Gary's comments. John, I think you made an excellent point that often we say we value partnerships, but we put it to the side of someone's desk, and they already have a 110% job, so so the partnerships might start and then fall apart. So if we're actually serious about these partnerships and the intersectors or interdepartmental types of collaborations, we actually need to invest in it. So, in the Housing for Health initiative, we actually have a partnership coordinator whose job is to manage the collaborations and the partnerships. So she doesn't do the research, for example, but she, and she's not the person necessarily like advising the developer team on specific interventions, but she's managing those partnerships and ensuring that they stay robust and connected. So, in that partnership, we've got over 200 partners in 6 provinces, many in Alberta. And so the management of them is already a full-time job. So it has to be someone's job or it'll fall off the desk. So I think if we're serious about partnership initiatives, we've got to fund them, I think is the point. And then with respect to, who determines, what we do or what the priorities are, I think socially, as a society, we've got roles to play in that dialogue. And we may not be able to take everything on at once, but we do need to start to prioritize and take them on. But I think in our individual organizations and in our individual lives, there is something that we can find to do in terms of improving the health and well-being lens from a determinants of health perspective.
Yeah. Great summary. Well, again, I want to thank all of you for the conversation today. This is a really important one, and I think there's some really good reflections for all of us in the work that we do every day, from small interventions to sort of big policy changes that we can make. So thank you, panelists, for this great discussion. And like Reg said, we have the room till 10, so feel free to stay and chat and approach any of our panelists to talk a little bit more about this. Thanks.